Hi, this is Dr. Rosen-Carole, Director of Lactation Medicine at the University of Rochester. You're watching this presentation because someone along the way has worried that your baby might have a tongue tie that could be impacting breastfeeding. So we're going to talk a little bit about what is a tongue tie and what we do about it here if we need to. First, let's talk about what is a tongue tie. Everyone has a lingual frenulum, which is the band under your tongue. You should be able to see it if you look in the mirror or feel it if you put your finger under your tongue. In 1 out of 10 babies, this lingual frenulum is either too far forward or tighter down than it should be, and we call this a tongue tie. And not all of these tongue ties will make breastfeeding difficult. So about 50% of these will cause trouble with breastfeeding. When we talk about tongue tie, we talk about them in terms of types or anterior and posterior. We start with type 1, which goes all the way to the tip. Type 2 is slightly behind the tip. Type 3 is thin but farther back. And type 4 is also referred to as submucosal or a posterior tongue tie. It's difficult to see without lifting up the tongue. And the type doesn't correlate with how well the tongue works. And so we have seen type 1 tongue ties with babies who are not having breastfeeding difficulties and type 4 tongue ties with babies who have significant breastfeeding difficulties. There are a few very common scenarios for tongue tie with newborn babies. Sometimes you'll have a high tone baby where mom has had a rough delivery, has lots of nipple pain or vasospasm or a squashed nipple after breastfeeding. And the baby might have a very small mouth, be screaming or biting at the breast, thumbing or clamping down. They might have a tight neck, and they might be fussy, gassy, or have GERD. Another typical scenario would be a baby with lower tone where the mother initially has stronger supply, but it goes down over time because breastfeeding doesn't feel like much. These babies might require waking to feed or triple feeding, and the baby might have other medical complications or show other signs of fatigue, time to organize a suck, and generally have a hard time getting the milk out so it isn't gaining weight at the breast or is falling asleep at the breast. These are only 2 typical scenarios. There are other ways that babies can present with tongue tie. Many people are worried about their baby's tongue tie and how it will affect their speech development. And unfortunately, at this time, we have very limited evidence about that. Certainly, there are older children and adults who will have difficulty with speech until their tongue ties are clipped. We just have no way of knowing how often this happens. Another myth is that these will stretch out over time, and they don't, although we suspect that people learn how to compensate with them. Some adults with tongue tie will report trouble with eating certain foods, licking ice cream, cleaning their teeth with their tongue, perhaps creating cavities, gaps in the teeth as created by upper lip ties, French kissing, and other things people do when they're older. Again, it's just difficult to know how often these things happen. Lip ties are another controversial area. Unfortunately, we really have very little data about the role that lip ties play in breastfeeding. We find that many lips are tight while the baby latches because the tongue is tight, so it compensates for the tongue being unable to create a proper latch. And it doesn't necessarily correlate with a gap in the teeth. Flexibility seems to be what matters most when we look at these babies clinically, and this is an example of an inflexible upper lip as opposed to the one above, which is a flexible upper lip. If any of these are impacting breastfeeding, we can perform a frenotomy. The frenotomy procedure itself is very old. There are references to it even in the Bible. These are plaques from the 1600s showing the tools that were used for frenotomy back then, which are very similar to the tools used today. If we perform a frenotomy today, your baby will be swaddled and given cold breast milk if you would like, or sugar solution. The tools look almost identical to how they looked in the 1600s. We lift up the tongue and clip until we see a diamond in the back. There's good evidence that the frenotomy procedure can improve the feeding experience and decrease maternal pain, but a little bit less evidence for improving the amount that babies get out of the breast for breastfeeding or for weight gain. There's some evidence for decreasing gassiness and gastroesophageal reflux, but in all of these, we have seen longer breastfeeding. We call frenotomy a low risk but not a no risk procedure. As with any procedure, you could see some bleeding. If your baby bleeds more than we expect, there are medications we can apply, and the worst case scenario would be to need to go to the emergency room or the ENT office downstairs for evaluation to get a suture or stitch placed, and that is incredibly rare. It is also possible to clip other structures in the back of the mouth, including the muscle of the tongue or the salivary ducts. Anytime you cut anything in the body, you could get an infection. Again, incredibly rare. These potentially can regrow, and every baby will end up with a frenulum under their tongue. Our hope is that it doesn't regrow restricted. There is, again, limited evidence about how often these regrow. Potentially 10 to 30% will regrow with some amount of restriction, but very few will need clipping again. And then finally, it might not help the problem. For posterior tongue ties, we anticipate that about 60 to 80% will improve. For type 1 and 2 or anterior tongue ties, we anticipate that 80 to 90% will improve after frenotomy. Frenotomy is not the only thing you can do for babies with tongue tie. There are many body workers in Rochester, like chiropractors and craniosacral therapists. There are occupational therapists, speech and feeding therapists, as well as physical therapists that might be able to help, particularly if the baby has any neck tightness. Many people will also try nipple shields or supplemental nursing systems as shown. Some people will be triple feeding or pumping and feeding. Another alternative would be to get this done by laser. It's important to note that there are no data comparing laser with scissors, although with the laser there's very little risk of bleeding. The parent is asked to step out of the room for most of the laser providers locally, and it is covered by dental insurance, which can be complicated if infants aren't yet signed up for their parents' dental insurance. The tongue tie procedure is painful. Afterwards, newborn babies and Kalmar babies tend to have very little fussiness, whereas older babies or fussy babies can have a few days. In order to help them, you can do lots of skin-to-skin feeding, cuddling. We will give you the dose of Tylenol that your baby would need if they have trouble settling at night or having trouble eating. Generally, people will only need one dose of this. It's important not to mask a fever and to remember that a fever is a medical emergency in babies under 2 months of age. Bleeding at home after a frenotomy is very rare. If this does happen, just have your baby suck on something, a pacifier, breastfeed. At the worst end, you could apply some pressure with a cold washcloth while giving a call to your pediatrician. We have not had anyone need to do this. Your baby may also spit up some pink, which is blood they've swallowed, or pass a black stool, which is again blood that they've swallowed and digested. And we do recommend that you slowly normalize breastfeeding. For type 1 and 2 tongue ties, breastfeeding can get better very quickly. For posterior tongue ties, it can take a little bit more time. And so we recommend that you continue to feed the baby the way you've been feeding the baby while you work on normalizing breastfeeding. Scars do turn white before they turn pink again, and this is normal. If your baby is a little jaundiced, the scar might even have a yellowish tinge. Signs of infection include pus, pain. Sometimes babies will refuse to eat, sometimes they won't wake up to eat, or they might develop a fever. This is very rare, but if any of it happens, either call our office or your pediatrician during off hours. In a few studies of older children, suck training afterwards was a good way to help the tongue get stronger and reestablish function. And so we do recommend suck training for your baby But because there is no evidence in this age group, we do want it to be gentle and fun. So if it causes your baby any distress, please don't do it. The way that we do it is by washing our hands, putting breast milk or sugar water, which we'll provide you with, or formula on your finger if you're using formula. And we'll teach you how to do a suck tug of war, pushing back on the baby's tongue for a few seconds until you feel the tongue coming out and cupping and waving, and rubbing the lower gums side to side to watch the tongue follow, helping those lateral muscles of the tongue to get stronger. If you have any questions, please let us know. Our goal is to make sure that you're comfortable with whichever decision is best for you.